All right, party people, we are back at it with another one. Let's get it. So we've got a 60-something-year-old dude with chest pain, blood pressure 80/60. His pulse ox is 88. He's got tachycardia and tachypnea and bilateral crackles. You see this ECG? And then I ask you, what will be decreased in this patient? 3, 2, 1, peekaboo. All right, let's go over why the correct is correct, as well as the incorrects are incorrect. We have a 60-something-year-old dude with ongoing chest pain, so it could be many things. You see that he has tachycardia, tachypnea, a normal respiratory rate is 12 to 16, as well as hypotension. His pulse ox is 88. Now we have to stop here so that we can clarify. Pulse oximetry measures the percentage of hemoglobin saturated with gas. The reason I'm saying gas is because standard pulse ox cannot, I repeat, it cannot differentiate between carbon monoxide and oxygen on hemoglobin. There is a special device called a carbon monoxide oximeter that can distinguish between CO and O2. This is very high yield for your licensing exams. For example, you'll get a question where it's wintertime, guy's using a heater, he's lightheaded, and pulse ox is normal. That is expected in carbon monoxide poisoning. Pulse ox will still show around 100. It's falsely elevated because of the carbon monoxide on the hemoglobin. For most of you watching this right now, your pulse ox is around 100. If it drops to 94, guess what? You're going to the hospital. Now, in the case of polycythemia, in that case, it actually is normal to have a pulse ox of 94 because you have more hemoglobin and it's less saturated. So the percent saturation is slightly lower than 100. That is normal and to be expected. Another key concept is that O2 content in the blood is the total of PaO2, which is your dissolved oxygen, combined with your hemoglobin-bound oxygen, O2 bound. The pulse ox measures the bound portion only, not the dissolved portion. So in polycythemia, hemoglobin of 20, let's say, your PaO2 will be normal. Whatever your blood can dissolve, it can dissolve. However, your pulse ox might be decreased because you have increased hemoglobin with less bound. Now, for added bonus material, indications for home oxygen therapy. If your O2 saturation is less or equal to 88, if you do not have cor pulmonale, that's a PaO2 of about 55. Or if you do have cor pulmonale, we're looking at a saturation cutoff of 89%, which is a PaO2 of about 60. Now, they're not directly going to ask you, should this patient be sent home on O2? But they'll give you an example of a patient on 92% room air. He specifically does not meet the threshold, and then you have to eliminate that particular type of answer from that question. All right, back to our patient here. So he's got bilateral crackles. This is classic for pulmonary edema. This implies left-sided heart failure. This, what you're seeing on the ECG, is a myocardial infarction. So when the ST elevations are in the anterior leads, you know that's an LAD infarct, aka anterior MI. All right, so let's run through the physio. You have an increased left atrial pressure. This backs up into your pulmonary circulation. Increased pulmonary capillary wedge pressure. This leads to fluid transudation into alveoli and interstitial space. The result after all of this will be pulmonary edema and crackles. So let's work through these answer choices. In terms of arterial lactate, this is wrong. If anything, it would be increased. All right, so you have to know about this. In shock, it doesn't matter what kind, if it's cardiogenic, hypovolemic, septic, you will have poor perfusion to your organs for a host of reasons. So you have less O2 delivery, your body will switch into anaerobic metabolism, your lactic acid will in turn increase. This results in metabolic acidosis and in turn a decreased serum bicarb. Lactate increases, not decreases. Next up, pulmonary vascular resistance. This is also incorrect. This would be normal or slightly increased. Let's run through it. If you have pulmonary congestion, there's more blood in the lungs. This triggers reflex vasoconstriction to protect the capillaries. So you have increased pulmonary vascular resistance due to smooth muscle contraction. The mechanism is increased hydrostatic pressure, which results in venous constriction. Next up, we have renin. Renin is also incorrect. If the heart isn't pumping properly, you will have poor renal perfusion. Kidneys compensate by activating RAS, RAAS. This increases renin. This is a key pathophys mechanism in congestive heart failure and MI. This contributes directly to fluid retention and volume overload. Next up, systemic vascular resistance again is wrong. Your heart isn't pumping well, so you have decreased cardiac output. This results in decreased blood pressure. You'll have an increase in sympathetic tone. This is to compensate. This stimulates alpha-1 agonism, which results in vasoconstriction. The result is increased systemic vascular resistance. Also, there's a decreased stretch of the baroreceptors in your carotid sinus. This will increase sympathetic outflow. Finally, we get to the correct answer. This is venous oxygen tension. Now, if your oxygenation in your arteries is poor, then obviously venous O2 will also be poor. There's less oxygen being delivered, less oxygen returns. Just keep that in mind next time you see a question that's similar to this. You have to understand the physiology as to how to get to the correct answer. It does make perfect sense. You just have to work through it and don't get intimidated by whatever nonsense they hit you with. All right, if you found this helpful, please subscribe. Go crush it.